Okay, so when we start with the maxillary central incisors, we have several pieces of anatomy to learn about. The nasal septum is the long piece in between the nasal fossa. Sometimes people get confused because they think of a spine as something long and straight, but in this anatomy, our nasal septum is the long, straight piece of thin bone or cartilage or whatever it's made of, that's in between the I guess bone, thin bone, in between the nasal fossa. The nasal fossa is going to show up as radiolucent, just like two large cavities, right? Sometimes there is other structures in there, inside the nose, this like kind of white area over here. What's it called? The conch, the nasal conch, but we don't memorize that for the exam. So I don't really focus on it. So we have the nasal fossa that's radiolucent, the nasal septum that's radiopaque, and then the anterior nasal spine, which kind of looks like a little bit of a white triangle, maybe. It's if you have a skull and everything removed, you know how the bone kind of curves up and out a little bit into like a point inside the nose or at the nose. That's the anterior nasal spine. There are two radiolucent areas, and so you have to let the arrows help define what you're looking at. So if I'm just pointing in between the roots of the maxillary 8 and 9, you're going to be like, is she pointing to the incisive foramen or is she pointing to the median palatine suture? So let the arrows help guide you. Critically think, is this arrow encapsulating it? Like, are there three arrows and they're kind of in a circle, or are there arrows that are up against a line? So it's so, to me, I've stared at this exam so much, but I'm like, it's really obvious, but I think it needs to be said. Let the arrows help define what it's looking at. It is really laid out for you visually, like obvious. Yeah. So, and you'll see that in some of even the examples of what you're studying. But the incisive foramen is going to be, it's an area of the bone that's scooped out and thinner, so it looks radiolucent, and it usually looks oval. The median palatine suture is a part of the bone that just doesn't come quite together, and so there's a space there, and anytime there's space, it's radiolucent. Other things that you can see is sometimes you can see the soft tissue outline of the nose and the soft tissue outline of the lips. If it's lower, like across the teeth, it's probably the lip. If it's a little higher up and it's across maybe the roots, it's probably the nose. So you can just think about it anatomically, the way it shows up. Sometimes you can't see it at all. So obviously on the exam, I'm gonna show you a picture where you can see it, but um, sorry, trying to advance it and it doesn't want to go. So this is just what it looks like on the skull. So it's pointing to all these things, the septum, the fossa, the spine, the suture, and the foramen. So you can see it all on a skull. And then the skull next to a picture. So we have the nasal septum. Down here is the spine, anterior nasal spine, the nasal fossa. So if it's pointing down toward the bottom and it's asking about something that's radiopaque, what would it be? What would it be pointing to? If it was pointing down here or on the X-ray, if it was pointing down here, what would it be pointing to? Yeah, exactly. You guys got it. The floor of the nasal fossa. Anterior nasal spine on a skull, and then you can see this kind of triangular shape. And even through the spine a little bit, it's remember things get layered. You're looking at a 3D thing that's you're seeing in a 2D, so it gets layered. So even through the anterior nasal spine, all the way down, running down, you can see the suture. Can you see that? You see how it's a radiolucent line running down the middle? So sometimes things get layered on top of each other. Notice the arrows. This is what I was talking about. Notice how they are encapsulating it. You will see something very similar on the exam. So this is asking you about the incisive foramen. Yes, the suture runs through there, but this is pointing to the foramen. Now the suture is being highlighted. Okay, this is soft tissue of the nose. This can get a little tricky. I absolutely agree because it depends on the position of the patient. It depends on the size of their nose and the size of their lips and all this kind of stuff. But generally speaking, if you have something that's crossing over the roots, it's more than likely the nose. And I have had people bring up pictures before where they've called it the nose, and I'm like, well, I think that might be the lip only because it's so low. So this can be a little bit tricky, and it's a very light thing to look at. You're not looking at something that's really like really dark or really white. You're looking at something that's kind of like ghost, it's soft tissue. Yeah. There is a question on the test. Yeah, the lip and the nose are up for grabs, as they can be something that can be on the exam. And so that's why I just really say, like, look at the stack. If it's higher up, just guess nose. If it's real low, like over the crowns of the teeth, guess lips. And I mean, every year people usually do just fine on that question. But this one can be a little confusing because it's right at pretty much at the CEJ. So some people might be like, well, which one is it? But it's still above the crown. So I would still say default to nose if it's above the crown. Just because you think of where your lip lies, when you're taking a picture, and then where the nose would lie. But it can be tricky. I will admit it. Okay. So now we're just kind of going through, these ones are not labeled, so it gives you an opportunity to test yourself. And I do have I think there's a PowerPoint uploaded that has all of the answers in the notes section, but it just gives you, oh no, these are right here. Sorry. I don't know what I was just thinking. There is a PowerPoint where none of them are labeled, so that's what I was thinking we were looking at. But so it has A for the nasal septum, E for the foramen, again A for the septum, D is for the spine. And C, this is really tricky, but see, it's very faint. It's very, very light. We can see a little bit of a line coming across here. I wouldn't put something like that on the exam. It's just too light. But this is just pointing out that that density differential is, you can kind of see, like, especially on this central here, you can see a little bit of a density differential, and so that's the lip line. That's just not as obvious as some of the other things. Here's another example of the nose, the soft tissue of the nose, kind of much higher, and then you can see that density change down here lower on the crown. And so that would be the lip line. Okay, so that's the maxillary central incisor. So there's quite a few things that will be on the test from just that one PA. There's other PAs that don't have as much stuff, but that one does have a fair amount of stuff. Okay, this one is a little bit tricky because there's a concept that you have to get orientation correct. You have to know what teeth you're looking at, and sometimes it can be really hard because sometimes a canine looks more rounded like a premolar, and so it can throw you off. So orientation is super important for this one. So this one is highlighting something called the inverted Y, and it's not listed here. I think it's listed later, so maybe I should wait. But so let's just talk about what we do see here. So in between the canine and the lateral, there is again another area that's sort of a depression. Bless you. And that depression is referred to as the lateral fossa, and it's also referred to as the canine fossa. It is just a depression where right in between the lateral and the canine. That's where you give an injection. You give the ASA injection in that area. You go up a little bit higher toward the apex of the roots, but in general, that's your kind of at the mesial aspect of the canine eminence. And so if you refer to it as the lateral fossa, it's fine. If you refer to it as the canine fossa, it's fine. In all the resources and textbooks, it's referred to as both. So it just is what it is. Some people prefer one. But it helps to also, if you memorize it as both, that's okay too, because then it's between the lateral and the canine. So it kind of helps you with location. So Was that a question or no?
It's canine fossa. Could be.
Yeah, canine fossa, lateral fossa, either way, it's right. Okay, and then the other things that you're going to see is you're going to see the floor of the nasal fossa, and you're going to see the anterior portion of the maxillary sinus. And what you're going to see are those two things come together, and they're going to form what looks like an upside down Y. So this is the tail, the tail of the Y, and then you have one part of the Y coming down, making the floor of the nasal fossa, and the other part of the Y coming down, making the anterior floor of the maxillary sinus. It's referred to as the inverted Y. And that's the landmark, is where those two things kind of come and converge. But what will help you determine whether or not you're looking at when you look at that canine picture and you see the inverted Y, to identify the difference between the fossa and the maxillary sinus, you just have to look down and look at what teeth are below those landmarks. So what's below your nose? Like
They're not.
your centrals and your laterals. So if you're looking at a nasal fossa, you should be looking dropped directly down of that image, and you should see your central and your laterals. And then if you think about it, just you go a little bit posterior and you start to get to the beginning of the maxillary sinus, what's directly down below that? Yeah, your premolars. So when you're looking at a canine image and it's being labeled and it's showing an arrow labeling one kind of cavernous thing, just kind of look straight down and go, are those laterals or are those premolars? And if that sounds super easy, unless you get like a really weird image that has a lot of distortion and the teeth all look funky, then that can be harder. But there's still usually clues to it. You know, like a premolar is still going to have a bulkier appearance. You potentially could see the buccal and lingual cusp, whereas the central incisors and the lateral are going to look smaller. And, you don't see that depth of buccal and lingual, you just have the one incisal edge. So there are things that if you critically think through it, and so we'll go through some pictures here. So this is what it looks like on a skull. This is the inverted Y. Again, you can see it's upside down, and then the tail of the Y. And then here's an image. So here's the anterior portion of the maxillary sinus and the floor of the nasal fossa, and then the Y. So this is your inverted Y. Right about at the intersection is the canine, generally speaking, but obviously that can change depending on how people take the picture. And then if we look over toward the backside of the image here, we can see the premolar. So then we know that's got to be the maxillary sinus. And then if we look up above the fossa, we know that that's going to be, or we look up above the lateral, we know that's going to be the nasal fossa. So that just helps you stay oriented, and we'll look at more examples. And then this kind of radiolucent area between the lateral and the canine is our lateral fossa. So the floor, so this breaks that inverted Y. So the floor of the nasal fossa and the anterior border of the maxillary sinus, they form the inverted Y. And this is a really funky canine. This is some crazy foreshortening. There's lots of foreshortening in this picture. They just took a very, very super angled picture. But you can see it gives you a lot of visualization of the fossa and the maxillary sinus and this inverted Y. And then you just look down from the nasal fossa, you should see anterior teeth. You look down from the maxillary sinus, you should see posterior teeth. And so that's how you can help yourself stay oriented as to what you're looking at. And if on the exam, it asks, if it points at the maxillary sinus and it asks about a radiopaque structure, it's asking about the floor. So you should specifically write the floor of the maxillary sinus. If it is asking about a radiolucent area, then it's just asking about the cavity. So the whole open space, or the cavity portion of the maxillary sinus. So then you could just say maxillary sinus. You don't have to say the floor, because that's asking, that would be radiopaque.
So on that X-ray, the arrow is right over the line of the radio open, like that's the floor.
That's the floor, yeah. And like the question that blue arrow could have a question attached to it saying, what radiolucent landmark is this blue arrow pointing to? And so then you would just say maxillary sinus. But if it says what radiopaque, then you'd say the floor of the maxillary sinus. Yeah. Yes. So here's another image of the skull with the lateral fossa or the canine fossa, and then what it looks like on the PA. This is just the opposite side. So it's just highlighting yet another image again that shows this inverted Y. So back here we have what's this back here? Yeah. Yeah, maxillary sinus, floor of maxillary sinus, and then what would be up here then? Floor of the nasal fossa, and then what do we have in between here?
Lateral.
Yeah, good. And then the whole thing in general is just called the inverted Y. So the inverted Y shows up radiopaque, and it just looks like an upside down Y-ish.
Is that the person?
Yes, it can be. Yeah. The inverted Y is a landmark that you want to recognize. So lots of different images of the inverted Y because Kate, you guys already know just from taking your pictures on Dexter that the canine shots can look all kinds of crazy. And there's not as much space, so it's really hard to get. You want to get your canine centered, but you could, your vertical angulation can be steep. You can be more posterior than you meant. You can be more anterior than you meant. So the images can look all, and on a human it's going to be even more variable because people have different shaped palates and all of that. So you can see how it's really it's really different. But again, you have some clues. No matter what you're looking at, you have some clues. So like back here, this one, you might say, "Oh my gosh, there's crowns on all these teeth. How would I be able to differentiate?" But generally speaking, this tooth looks a little bit smaller than this tooth. This one seems to have some width to it, and it's bifurcated, whereas this is just a single, and we know our premolars can be bifurcated. So you just start to pull in this knowledge that you know and just start to kind of think critically about it, and it can help you differentiate between the anterior and the posterior on a canine shot. And it takes practice. It just takes looking at a lot of images, and you'll get better at it. Again, here we have our canine, we have our anterior teeth, posterior teeth, canine, posterior, anterior. This one is just that one again that's really a lot of foreshortening. It's taken at a strange angle. And the canine, look how flat the canine is. There's no like kind of pointy canine. So it almost looks like a lateral, really, but you have to find label your teeth, find your canine, label your lateral and your central, find your premolars, and then you can figure out your anatomy, maxillary sinus, fossa, inverted Y. So it takes repetition. So again, and here, I mean, this is another one with a lot of foreshortening. And this is now we're getting into good examples of vertical angulation error. So when you have these kind of images, when you take them in class, you can see the vast difference between taking a premolar that looks like this and taking a premolar shot where your image, your film was parallel to the tooth and your beam was perpendicular. It comes out much more true to size and true to shape, as opposed to if you have some distortion, then it looks very different on the X-ray. So would this be pointing to the maxillary sinus, or is it pointing to the nasal fossa? Sinus. Good job. Yeah. And then this whole thing, even though it kind of heads off over the posterior teeth, this is our nasal fossa, maxillary sinus, and then the actual lines are the inverted Y. What's the red arrow pointing to? Yeah, and that's a hard one. Like that's a hard picture to know, but you kind of get to the point where you're like, okay, that's a weird picture. It's not a good picture, but this is the inverted Y. I can kind of pick it up. And even though this doesn't look like a canine, that kind of looks like a premolar. So my best guess is that's going to be the lateral fossa or the canine fossa. So there's there's a finite amount of landmarks that you have to learn. And so by process of elimination, you're like, well, that's got to be the lateral fossa because there's nothing else it could be. Yeah.
The specific anatomy?
Yeah, so on Monday's group, I gave them the list for the piano, and then I'm gonna find on the break, I'll find the list for the PAs, and then you put those two things together, and you got the whole list. And I'll print it out for you guys too. I'll give you the one for the piano on tomorrow, and then the one for this, I can print them all out and hand them out to you guys too. Um, Okie dokie. All right, so maxillary premolar. So on the maxillary premolar, really there's just two things that you are going to notice. There's not a lot of things on the maxillary premolar, which is nice. Again, you're going to just have, you potentially could point out the maxillary sinus or the floor of the maxillary sinus. And then the zygomatic process sometimes comes down into the maxillary premolar shot. Not always, it depends on the angle, but the zygomatic process and the maxillary sinus, those two landmarks are close, they're overlapped, but the zygomatic process is thicker, much, much thicker, and it kind of looks like a J or a U, where the maxillary sinus is going to have a very thin floor and it's going to be mostly like open space. And so the zygomatic process is usually going to be, it's superimposed over the sinus. So this is these are really the only two things that you'd be asked for a maxillary premolar is to point out the maxillary sinus or the maxillary or the zygomatic process. So see what it looks like. This is a hard one. I would probably not use this image on an exam, but see how it gets kind of thicker and whiter back here? Whiter, not whiter, W-I-D-E-R, but also whiter. So that lets you know that this kind of thin part is the floor of the sinus. That's all the open cavity. And then it gets a little whiter and whiter. And so that's a little bit of the zygomatic process. I don't like that picture for a test, but that's what it is. So every time you're looking at different PAs, sometimes you're just picking up a little piece of something. Sometimes you see the whole thing really, really well. It just depends.
What is that little line in the between like the radio page?
Oh, this one, it's probably a septum. So there are like divisions of the sinuses. There's lots of sinuses and they have little divisions. And I don't test you. You might on some of your resources, it might say maxillary sinus septum or something like that, but I don't test you on the septums. But they're just divisions that divide up all the different sinuses. Okay, that's a good picture of the zygomatic process. I mean, you can really see the bulk of it, see that the width of it here, and then see how it swoops up this way. So this J is what we're really pointing at, but you can see the bone, like you can see how, because it's basically like your cheekbone area, and you can see the width of the bone, but it's this J that we're really looking at. So it gets superimposed over the maxillary sinus. So when the arrows are pointing to that area, just be really, really careful about what it looks like it's pointing at. Obviously this is pointing to the zygomatic process because if it was pointing to the sinus, it'd probably point down here, right? Where the sinus is where the floor is thinner, and it would try to differentiate between those two. So you just have to think about it. Where the arrow's pointing and what's the most likely thing. Just because it's in the same area doesn't mean it's the maxillary sinus. So just kind of pick out those things that are different. This is an example of both are there. You can see the zygomatic process here, but this is clearly pointing to the maxillary sinus, the floor of the maxillary sinus. And this is that's the zygomatic process. So just think if it's thicker, if it looks bigger and more, just whiter, then it's likely the zygomatic process. Here it is again. A lot of weird sinuses. Sinuses can be really low. The roots can be up in the sinus. That's why some people have a procedure called a sinus lift, or that's why their teeth hurt when they have sinus infections, because the roots of your teeth can be very close, to the sinus. So it looks like the sinus is just fell right down in. They've had bone resorption and remodeling because they lost those teeth. And so the bone has thinned out and gotten very, very, very close to the sinus. So this is all sinus here and here, but do you see this structure here and this kind of swoop? It's very radiopaque here. Those are the zygomatic process. And then this is pointing at the maxillary sinus. You see that differentiation? Yeah.
Why did you say our teeth are sick?
Oh, because our the apex of the apices of our maxillary molars are pretty close to our sinuses, and then some people it's really close. And so if somebody has like a really bad sinus infection, they can have a lot of their teeth can hurt. So sometimes people complain about a toothache, but it's really maybe they have a sinus infection going on, or vice versa. Okay, that's the premolar. So it's just those two things on the maxillary premolar, but they're close to each other. So you really want to differentiate between the two. Maxillary molar is pretty much the same thing with two extra little things added. So we have the zygomatic process. It's going to look the exact same, thicker, whiter, kind of a U or J shape. And then we have the maxillary sinus. So kind of same thing, just a little farther back. And then the coronoid process. Where's the coronoid process? Mandible. It's like the part that it moves when you open your jaw. So the coronoid process is part of your mandible. It's the only shot, the maxillary molar PA is the only shot where you might actually see a little bit of a mandibular structure. So that's really important to remember. So this little funky triangle that's poking down here at the bottom, that's actually the coronoid process. Well, the condyle is the part that goes in. I said it wrong. So if you think about things long enough, you'll correct yourself. The condyle is the part that is in the articular eminence but the coronoid process is the front part. So on your jaw you have this back part in the TMJ and then it swoops forward.
Is it visible in all of the?
Not all. So it really just depends on like your angle, but it's the only shot that has the possibility of seeing a mandibular landmark. And so it really depends on your patient's anatomy, the angle that you take the picture, but it happens quite often. I mean, it's not a rarity, but it's not in every single picture either. And then the maxillary tuberosity. So you can see this maxillary tuberosity is showing how it could potentially have like a third molar. If someone has an unerected third molar, that maxillary tuberosity is just your most posterior part of the maxilla there along the occlusal plane. And so sometimes some of these pictures are weird because I'm like, it looks like it's pointing to a molar, but really it's just talking about that part of the maxilla. So we'll look at some things here. So like here on the skull, it's pointing to the bone, the maxillary tuberosity, but here that's an unerupted tooth and it looks like it's pointing to the unerupted tooth. So I always think this picture is kind of confusing, but this is unerupted and there would be tissue and bone there. And that in clinic, we would call that the maxillary tuberosity, even though there is a tooth that's embedded in the bone that hasn't erupted. Some pictures don't have that, but this one does. I don't know. Okay, so, and then again, I don't love this picture for the coronoid process because you can't really see that good swoop, but that's what causes this density, this radiopacity. We have the maxillary sinus here, and then this is part of the coronoid process on the mandible. That's what's down there. So it's always going to be, if you're looking at the picture and you're looking, well, this one is an upper right maxillary molar shot. So it's always going to be down in the lower left. And then if you're looking at the opposite side, it's always going to be down at the lower right. So it's always going to be down by the most posterior molars of whatever shot. Whether you're on the right side or the left side, it's not going to be down closer to the premolar areas, more anterior, it's going to be the most posterior corner on the bottom. That's where you would see the coronoid process. Again, this kind of general radiopacity is picking up some distortion of the coronoid process. We have the maxillary tuberosity here. We have some of the zygomatic process here and the maxillary sinus here. This is a really good one of the coronoid process because like they added this little picture. But see, it's like a little triangle. So that's how they describe it, like a little radiopaque triangle in the lower corner, but it doesn't always look perfectly triangular, but that's the general shape of it there. Um, extra teeth. They got extra. Do you see that? They got their first and second molar, they got a wisdom tooth, and then they got another wisdom tooth. They got extra teeth.
Why does the muscular tuberosity doesn't look as solid, like both? Like on the picture on is like 28, which is.
Yeah.
Kind of like.
It looks yeah.
Normally look like that.
I think it's just sometimes it really depends on just the way the x-ray was taken. So it's definitely solid bone, but I do think sometimes the trabeculation doesn't show up as well. Sometimes maybe it's not, maybe they did have an extraction at some point and the bone hasn't like filled in as, heartily. I don't know. I mean, that's definitely getting a little bit above my pay grade, but sometimes I know it really is the way the x-ray exposed it. That can add to it. That can add to the weird look. Because that whole picture looks light to me. Like that whole picture looks kind of light. So I think it can be kind of funny like that. Okay, again, here's a very like the zygomatic process is taking over like the picture. So that happens a lot when we're very angled and we're coming through the zygomatic process at a very steep angle. When you're more flat, the zygomatic process is going to be at more the top of the picture. When you're very angled, you're going to pick up a lot more of it. So that's showing it there, and you can see the blue arrow is really pointing to the process, and the rest of it back here is pointing to more the bone or the arch. And then down here we have the cornoid process. Again, we have maxillary sinus all along here. That's just showing this the large sinus. It's all back here. Over that, you see the zygomatic process, little bit of the cornoid process down here. Orange arrow is the cornoid process. Purple is the maxillary tuberosity. Red is pointing like more at like the actual sinus, like maxillary sinus, like the cavity part of it, the open space. And then green arrow is pointing to the zygomatic process. Now that looks thinner than some of the other ones. Like you can see how it varies. Sometimes the zygomatic process looks thick and white and is just taking up the image. Other times you're just catching it at an angle where it looks thinner, but it still looks thicker than the maxillary sinus. It still has a thicker border than the floor of the maxillary sinus. So just remember that it's always going to have a thicker appearance. Even if it varies within itself, it's still going to have a thicker appearance. That's the whole maxilla. So that's everything that you'd need to know for the maxillary PAs. Should I take a break? Let's do a few more. Wait, what time is it? Oh, no, I should take a break. I don't know. I can't see the 12. Okay, yeah, 8:50. Yeah, let's come back at 9. I'm gonna print off your take-home quiz. So that's essentially half of the list. The other half, the Wednesday people, you'll get the panel list tomorrow. Okay, so now we're coming down to the mandibular incisors. And on the mandibular incisors, we have 4 things to memorize. You have the mental fossa, which can be around it can be around the roots, but it can also be around the apex portion, like the apical portion of the roots. So it varies in different x-rays depending on the angulation and the person's anatomy, but it's just a thinner, I mean, just think about how your chin is. You have like, your chin comes out and there's thicker bone. And so up here, it's going to be thinner. So that's called the mental fossa. And then we have the mental ridge, which, yeah. Yes, thank you I love the reminders, but I did remember to press record. Thank you for asking. I can always use a reminder. Okay, so mental ridge is that now it's on the lingual, and you can kind of feel like if you don't have mandibular tora, you can just sort of feel that ridge that comes down, and you just think about your chin. Just think about the anatomy of your chin, whether you're thinking about the outside or the inside, the bone's just thicker there. Sometimes it's very prominent and it shows up really well on a PA. Sometimes it doesn't show up so much. Straight down between the central incisors on the mandible, we have the lingual foramen, which is an area where there's a nerve opening where there's a nerve entrance or exit, I guess is what it would be. And then around that, the bone is thick and it's where there's like muscle attachment. And so the lingual foramen is the radiolucent area because it's an opening in the bone. And then the genial tubercles is sort of where the bone sort of thickens up and it's actually like where there's like tissue attachment. And it surrounds the foramen. So again, it's one of those things where you have a radiopacity next to a radiolucency. And so you really have to pay attention to the question because an arrow could look like it's pointing to either one. So it's like, what's it pointing to? Well, is it asking about a radiolucency or a radiopacity? Because they're opposite. So just have to really read your questions carefully when you take the landmark exam. Because otherwise it kind of looks the same. It's like, what's it pointing to? I don't know. So this is what it looks like on a skull. We have the foramen for A, the literal like hole in the bone, and then just an area around it where the bone is thicker and it's where there's again like muscular attachments and tissue attachments. And then we have this sort of scooped out thinner portion of the bone for the mental fossa, and then a thicker portion again for where the bone gets thicker. So for the mental ridge, sorry. Here's a picture on a radiograph. You can see the very clear radiolucent circle and then the radiopaque sort of surrounding it. And then we can also see where the bone gets a little bit thicker here for the mental ridge. And this area in general would be the fossa, mental fossa. The other thing you can see sometimes is like the edge of the mandible. I mean, depending on, as we come around, you can see like the terminal edge of your chin or the angle of the mandible, the border of the mandible, and then you just see airspace. Like this is just air, but this is the thick kind of bordering of the bottom of your mandible. So sometimes you can see that too, and that if you are ever curious as to what you're looking at. So this is just pointing out this anomaly of the bifurcated root. That's what the red arrows are. But again, we have the genial tubercles. It's not a super clear picture of the foramen, but you can see the genial tubercles there. Mental ridge on a skull, and then pretty well defined here on the X-ray. Fossa, just kind of a thinned out part of the bone. And so you can see the fossa lies in different areas. So it's just kind of this not well-defined radiolucent kind of area around the roots of the mandibular incisors. If you see something that is very, very well defined, it probably is a lesion of some kind. So the fossa, it doesn't have this harsh radiopaque, radiolucent look to it. It has more of a diffuse look. So if you see something that has very, very strongly defined borders in this area, you're probably looking at some kind of a lesion, periapical lesion, pathology, disease, bad things. Because you can see how in general from these other pictures, it just looks a little bit more radiolucent. It's not like super duper. It's just like you can see how it looks a little darker in that area, telling you the bone's a little bit thinner. But then when we come over here, this is like very well defined borders. So that's likely an abscess or a series of whichever one of those teeth is causing the bone loss there. So this is probably pathology. These little straight lines that are falling down from like coming straight down, those are called nutrient canals. I don't feel like you see them that often, but you can pick them up. So these kind of little straight lines coming down. Okay, on the mandibular canine, we have a few things. Again, we can see a portion of the mental ridge. We sometimes can pick up the lingual foramen and the genial tubercles depending on the angle of the canine shot. Again, very oftentimes because we can pick up some premolars, sometimes we can pick up the mental foramen, which is another area where that's another place where you give an injection. You give the mental injection on by the mental foramen. And so this is another potential. It's not necessarily always going to be there, but these are things that you can see. And then the inferior border of the mandible, just like you could see it in the central incisor shot, you pretty much can see it all the way along different portions of the inferior border of the mandible, depending on the angulation that the clinician took the x-ray. So here we have it on the skull. We have the mental foramen over here. We have the thick portion of the mental ridge here. We have the foramen, the lingual foramen and the genial tubercles here on the skull. And then here we can see the mental ridge. That's pretty much all you can really see on this picture is just the thickening of the mental ridge. It's really not much else to see there. Here you can see the lingual foramen and then that's surrounded by the genial tubercles. And then you can see the mental foramen always looks kind of just, and you saw it on the pano. Sometimes you can see the mental foramen really well on a pano. And it's just where the mandibular canal that houses the nerve, it's where it terminates. So it starts up at the mandibular foramen and it ends at the mental foramen. And then all along is the canal. And so that's what the mental foramen is. It's just the terminal portion of that where the nerve is housed. So you can see the mental foramen on the skull, and then you can see it over here. It's usually between the premolars. Sometimes it's under one more than the other. But generally speaking, it's kind of somewhere in between the two. And then we can see the inferior border of the mandible there. For the mandibular premolars, it's kind of more of the same. You'll just see them in different locations because it's a premolar shot. Very often you can see the mental foramen. Sometimes you can pick up some of the mandibular canal. The internal oblique ridge, do you guys remember the external oblique ridge? The external oblique ridge comes straight off of the molars. The internal oblique ridge sort of rides down, but then it drops down and kind of goes over the roots. So there'll be more pictures that show it a little bit better. So if you think about it stacked, this is the way I try and get people to think about it, especially when we get to the mandibular molar shot. If you think about it in layers from like the occlusal surface of the tooth down all the way down to the apex, if you think about it in layers from like top down, think about it as internal oblique ridge, and then you're going to have the submandibular fossa with potentially the canal running through it. And then you're going to have potentially, you might see the inferior alveolar or the inferior border of the mandible. But if you kind of have to stack it like that in your mind, and that can help you differentiate from what you're looking at. Especially when the canal is being pointed out and the inferior internal oblique ridge, because those two things people are like, is that they get them confused. And I'll show you a few things how to differentiate. Okay, so here's the skull. And you can't see the canal because it's inside the bone, but that's where the canal would run. It's opens by the premolars for the mental foramen. This dip, as our mandible, so you can especially feel it on the lingual, because that's where it is. It's called the submandibular gland fossa because it houses the saliva glands. It houses the submandibular glands. They're kind of nestled into that part of the bone that sort of is scooped out. And so that's why it looks radiolucent on the film, is because, again, anytime your bone is thinner, it's going to look more radiolucent. If it's thicker, it's going to look more radiopaque. And so the glands are kind of in that area you can kind of, if you stick your tongue into either side, it kind of just feels like it kind of goes in a little bit. And that's where the glands are. So on this is kind of what I mean by it's stacking. So the top here, we have the internal oblique ridge. This actually runs below the apices, but sometimes it'll run right through the roots. So first we have the internal oblique ridge, and then below that we have the submandibular gland fossa. Now that's going to be a larger area. I like to think of it more as like an oval, like a larger oval. And then sometimes on the pictures you can see a faint image of the canal running through the fossa. So you can pick up these very, very thin white lines, which would be like the wall of the canal. And then inside of that, the radiopaque part would just sort of, or radiolucent part would just sort of dissolve into the rest of the fossa. So you can kind of see it here a little bit. See how there's like this super thin white line running through the picture? You guys probably see it better on your laptop than on the projector, but you can kind of see like a thin white line, but it's in that area of the fossa. So this is some of the harder stuff to differentiate because your eye has to get keen on looking at these different structures, picking up the faint shades of gray differences. So the mandibular canal runs downward from the mandibular foramen. So we have an opening up here. That's where it's another place where we give an injection. We're trying to get close to that opening of the mandibular foramen. And then the nerve runs all the way down our jaw and it exits at the mental foramen. So when we take these pictures of the premolar and the molar, a lot of times we can see portions of that canal. So if you're thinking about the walls of the canal, just like the maxillary sinus, they're going to look radiopaque. If you're thinking about the hollow tube, if you think about it like a garden hose, just the middle part where the water runs through is going to look radiolucent.
So can you go back to
Yeah.
the picture that we were looking at? So the arrows on the last picture, the arrow that is pointing down is pointing at the mandibular.
Yeah, it's not, I will admit this is not a great picture of the mandibular canal, but yes, it's trying to give you an example that amongst this big radiolucency, which some of it is the fossa, there is this other part of anatomy that's running through it. So that's what that's trying to highlight.
And the arrow that is pointing out towards the back is the internal oblique line or ridge, sorry.
Yeah, I
Or
think
the
that's
two
whole
little
thing.
lines or the whole ridge. To say
Let me
or
see
just
what does it say? Passing close to the roots of the molar is below the so this is just trying to highlight just the canal. So it's kind of saying like these things are close by. Up above is the internal oblique ridge. They're not really pointing it out on that x-ray, but we know that a little higher up would be the internal oblique ridge. Down from that, the larger radiopaque area would be the fossa, but inside of there, sometimes you can see the mandibular canal. So they're just trying to highlight from this picture the mandibular canal. It's not a great picture, but I think it's actually good to look at something where it's there but not super obvious. On the landmark exam, I give you more obvious pictures because I try to be nice about it. Okay, so this is the submandibular gland fossa. You can see how it's a thinned out portion of the bone. It's running down by the molars. And so like I said before, I like to think about it as sort of an oval, like a large oval around the mandibular molars. So that's a submandibular gland fossa. There's the mental foramen. Yeah, you're usually going to see it down by the apex of the premolars or between the premolars. It's usually a pretty good circle, it's rather, uniform in shape. And so we have basically more of the same. It's just going to look a little bit different because now you're on a molar shot instead of a premolar. But it's basically the same anatomy. The only thing we're actually adding is now we're adding the external. So we're not adding new stuff. It's just going to maybe look slightly different because now you're looking at it from a molar as opposed to a premolar. So here's another opportunity to kind of think about it in layers. So the external is going to be the highest point, and that's going to come right off the back in the image, it's going to look as though it's coming right off the back of the molar. That's your external. And we've already learned about that for orientation, making sure our mounting isn't upside down. So our external oblique ridge, and then sometimes you can see it as it almost like they branch off from each other. And then other times they can look stacked, like external, internal. But the internal always is lower than the external, and it generally is running over the roots of the molars. So it's like a thicker white line that runs over the roots. And then below that's going to be your fossa, your submandibular fossa. And then within the fossa, sometimes you can see the canal. So it's the same thing as with the premolar shot. It's just we're farther back, and so sometimes you can see it a little bit better. So here's some of it on a skull. So we have, so if it was an X-ray, I would like if it was an X-ray, we would look at it and we'd say, there's your external, right? Because it looks like it's coming right off of the molar. But on the skull, they're actually both kind of dipped down. But this is the only one I don't like looking at it on a skull because I feel like it's confusing. Because when you look at it on an X-ray, it's taking a three-dimensional thing and it's flattening it out. So the external oblique ridge looks like it's coming straight back from the molar. But technically, this is where the external oblique ridge is. The mandibular canal runs inside of the bone. We have the internal oblique ridge, and it's where the bone sort of gets bulbousy and thicker right before it dips into the submandibular fossa. But it all kind of rides up the ramus of the mandible. So this, I like it better because see, it's like this, it looks like it's coming straight. So it's an easier way to identify because you're like, find your terminal molar and that thicker white line is your external oblique ridge. Down from that's going to be your internal oblique ridge. And then we're looking at the submandibular fossa. And then within the fossa, we can see this kind of ghostly feature of the mandibular canal. And I like this picture. I feel like it differentiates all of it pretty well. It might not be as clear on the projector, but on your laptop, you should be able to see it pretty good. And you can see kind of how it's like layered. So external oblique ridge up here, closer to the top, internal oblique ridge down here at the bottom, submandibular fossa. This has a lot of foreshortening. This person looks like they have bone loss. They don't have a very bulky mandible, and then the angle that they took it, everything looks very short. So it's a weird image. They're missing teeth, but nevertheless, you can see those landmarks there. So external oblique ridge up here, internal oblique ridge down by the apices, and then below that is the submandibular fossa. Is this the same picture as before? I think it's the same one. External, internal, submandibular fossa, and then this is just a nice picture of the canal. It just shows the canal pretty well. I feel like that's the same one as before, but maybe not. Submandibular fossa. This is on the skull, and then down here, internal oblique ridge, external oblique ridge. Again, kind of a weird picture because there's a lot of bone loss there. This was probably an older person with, they've had probably a fair amount of bone resorption. And so everything looks much thinner, but you have fairly prominent because it's the thickest area of bone. So as they've lost bone through the years, this is still going to be the thickest area of bone, external oblique ridge and internal oblique ridge. Then you can see how thin it is down, their inferior border of the mandible is very close to their teeth. But it's a very strange angle of the that they took the picture at too. This is just kind of highlighting, when we talk about getting our wisdom teeth taken out or teeth extracted, and they say, oh, you got to go to an oral surgeon because the apices of your teeth are lying very close to the nerve. The dentist gets a picture that kind of gives them a general idea of where the nerve is and where the tips of the roots are, but they can't really see if the apex is literally lying on the nerve, or if it's if it's curved or something. So they take the three-dimensional, the CBCT scans to try and give them a better view, but the more often than not, they just send it out to the oral surgeon because you can see how close, see this wisdom tooth has very twisted apices, and it's right there at the nerve. And this one, the same thing, it's just lying right over it. So they don't want to cause permanent nerve damage or some kind of like permanent numbness for the patient. Okay, so let's practice. So what are the red arrows pointing to? Good job. Floor of the nasal fossa. What's the red arrow pointing to? Coronoid process. Coronoid process is the red arrow. What's the white arrow? Maxillary tuberosity. What's the yellow arrow? Zygomatic process. Yeah. All kinds of weird pictures, but you can still, if you kind of know what should be in that picture, you can kind of figure it out, even if it doesn't look like totally what you think it should look like. What's the green arrow pointing to? Lingual foramen. I know fossa foramen, it's kind of weird, but fossa is generally like a thinned out area, and foramen is like a hole in the bone. So the small radiolucency identified by the green arrow is the lingual foramen. What about the blue arrow? What's that highlighting? Yeah, internal oblique ridge, and so the orange arrow? Sublingual. So if you sublingual gland fossa. So if it's the canal, it's gonna kind of sandwich it. I kind of help you guys out and I like sandwich it top and bottom, and it's a little more narrow. If it's the sublingual gland fossa, it's gonna be a little larger. So that's the main differences. You're gonna see kind of like it's gonna track with the canal, and if it's the fossa, it's gonna be like a little bit of a larger area. What's the yellow arrows pointing to? Zygomatic process, and the red arrow? Yep, floor of the sinus. If I said radiopaque, floor of the sinus. If I said radiolucent, you could say just sinus. What about the orange arrow? Nasal septum. Good. How about the blue arrows?
Nasal spine.
Suture. Median palatine suture. Median palatine suture. Median palatine suture. How about, this is a weird one. How about the red arrows for this one? Kind of hard one. Uh-huh, mental ridge. Good. What about the red arrows for this one? Uh-huh, mandibular canal. See how they're sandwiched? That's kind of how it'll be on the test. And then, okay, we can't do the dental materials game because I haven't talked about that. And I have about 20 minutes, which is more than enough time. I just have a few slides. So all of these pictures, let me just kind of run through. All of these pictures are good tests. And I do believe, I'm going to double check, but I do believe I have the PowerPoint with all of the answers. What do you guys think that is? Yes, tip of an instrument. Someone went into a deep pocket and broke off the tip of their scaler. It happens a lot. No, not a lot, but it happens. It absolutely happens. We have these cool little magnetic, worst case scenarios, the patient would have to have surgery. But almost always, if you can feel it happen, you're scaling, and all of a sudden it's like dink, and you're like, oh crap. And so then we have these cool little magnetic things. Sometimes it comes out of the pocket, like on, you won't do it very deep. And then other times if it's pretty deep, you just stick a magnetic instrument in there and it attaches, and you just have to be really deliberate and careful. But don't over sharpen your instruments because that can happen. Okay, so the answers will be, I'll make sure that I have uploaded that other one that has all the answers. But let me switch out of this and pull up the dental materials, and then we can actually go over it. It's where am I? See, it says key to PowerPoint. I'm pretty sure that's going to have your answers. Here's another dental material kind of practice thing, but the pictures aren't great. It's just for practice. That's probably not one of my favorite resources, but it's there. Um, okay, so I'm gonna open this up. Okay, so for dental materials, this is definitely not like inclusive of every kind of thing you might see, but it's just giving you an idea of what's out there. The PowerPoint that we just left, those slides are really, really good because they're gonna add in other things like, like an amalgam tattoo or, amalgam that's embedded in the tissue or a space maintainer or something that's like ortho. And so definitely go back to that after we go through this. So the main thing is thinking about the radiopacity. So obviously metals are going to be whiter. Composites are going to be a little, things that are made out of like plasticky type materials or polymers and things like that. They're not going to be as white. And then if it's some kind of an old material, like really old material, they might have put something in that didn't have any radiopacity. And so then it could look like a cavity. But that's not as they don't do that anymore. But if it's an old material from a patient, maybe like in their 80s or 90s, then maybe they might have retained some kind of old material. So you just have to kind of be aware of the way things show up. Obviously, this is amalgam. Amalgam is an amalgamation of different metals. It's tin and silver, and mercury is the liquid that kind of gets it all bound together. You'll learn all about it next semester. But it shows up bright white. And so you can see different shaped fillings. We like to pay attention to the margins of these restorations. We like to see how smooth they are, if there's overhang, if there's recurrent decay. You can see like this one has a very large overhang. So when they placed that filling, they didn't do a good job contouring it to the tooth. But you can see all of these bright white amalgam fillings, different shapes and sizes. So here we have a couple different things. Here we have an amalgam fragment. I don't know if I'm not sure exactly where the composite is supposed to be because that looks too white to be composite. This is definitely amalgam fragment there. I don't like this picture. Not quite sure if that's supposed to be. Some composites are more radiopaque, but that seems almost too radiopaque. But anyways, this for sure is amalgam fragments, and that can happen when they're placing amalgam and the amalgam, or when they're removing old amalgam and it can get embedded into the tissue, and it can be just a dust. It can be just a dusting and it can show up radiopaque on I guess that would have been it. I mean, it's just more radiopaque than I guess I would have thought. But I guess this over here is the composite. I like it better to see it a little bit more contrasting. But these materials are constantly changing, and the makeup of them are constantly changing, and they are making them so that you can see them and they stand out better. And you can see that clearly because this is a great example of where you can see how radiolucent the composite was, and then this composite that's more radiopaque. So the different manufacturers make different products and they put different things in them to have them stand out better and show up a little bit better. So these are all composites. And it's very common to see composites in the anterior because it's more cosmetic, and you wouldn't see amalgams necessarily through the anterior teeth because that just wouldn't look as cosmetically pleasing. A gold crown is going to have very, very smooth edges. So sometimes students are like, how can I tell the difference between a large amalgam filling, and a gold crown? A gold crown is going to be just solid. I mean, it stops it's like, solid metal wrapping around the prepped tooth, and it's formed. It's not, the dentist doesn't make it there. They don't carve it. It's pre-formed. So it's going to have a much smoother appearance. You can see the way they put in the amalgam, the dentist they prep the tooth, they drill out the tooth, and then they push the amalgam down into it, and then they carve the top of it. So it's going to have much more irregular lines, where a gold crown is going to have much smoother lines. Zirconia is more of a modern material, and again, it's going to have that smoother look to it. It's going to just look more like it's been, created in one step as opposed to pushed in layers or in segments and carved. It's going to have more of this kind of consistent, and of course, it's going to be covering the entire tooth, so you're not going to see any portion of the natural tooth. A crown just covers the entire thing. So whether or not you're looking at zirconia or you're looking at gold, that can be hard from just an X-ray, but this is a little bit more radio lucent than the gold. I mean, this has a little bit more of a white look than the zirconia, but there's still hard to say. So when I test you on these things, I don't put things that you could, for a crown, for example, it's like I wouldn't put a zirconia crown and a gold crown, but I would put a PFM, which is porcelain fused to metal, and we'll look at that next, with a gold crown. So those you can differentiate easier. Some of the other crowns you can't really differentiate. The EMAX or CAD CAM, if they're made of just like porcelain, sometimes have far more radiolucency, or if they're a veneer, they have far more radiolucency, but then it depends on the material. So the dentist might use different materials, but you can kind of see where the tooth has been prepped. So these are probably more veneers or a very minimal prep on the tooth. And then you can see the material outline. So you can kind of see the prep portion, and then the rest is like a porcelain crown. So they don't appear nearly as white as metal. EMAX or CAD CAM is a machine that the dentist has any of the dental assistants worked with that. Dentists like having them in their office because they can manufacture this stuff in their office as opposed to sending impressions off to a lab, and then the lab charges a portion of the fee, so they have everything in-house. The machines are expensive, so they have a big overhead cost to buy the machine, but then they have more profit in-house. Stainless steel crowns are radiopaque, but not totally radiopaque, because oftentimes they're just a thin, it's a temporary crown that they use a lot of times on kids. They might even use it on an adult. They're preformed crowns. Their margins are not great. See how the margin it kind of just looks like they plopped it on the tooth, as opposed to back here. It has a little bit more of like a nice kind of refined edge, whereas the stainless steel just kind of looks a little bulky, and it can look really, really bulky, or it can look kind of bulky, and it's not quite as radiopaque. It's just thin stainless steel. So it's a temporary crown, usually for kids. If they have a big cavity, they'll put stainless steel crowns on kids on their baby teeth. So that's what this is. And you can see the margins are just horrible, but they're just trying to buy time until, actually, no, that's not a baby tooth. That's an adult tooth, but it can look very similar to that, with those really bad, like oversized margins. So it can look really similar to that. But usually they'll put that on while they're waiting for the permanent crown to be made, or if sometimes patients don't have money for a crown, and so they'll just say, I just do a stainless steel crown. So the situations can differ. So down here we have some porcelain crowns. You can see the really strong outline of the prep, and then they've lined it with some kind of radiopaque cement, and then the prep tooth is around it. Here we have some PFMs or porcelain fused to metal, and then we have a root canal. So there's a couple different things with the root canal. We have a screw, and then we have gutta percha. So sometimes whenever you have a root canal, the tooth becomes more fragile. You've lost the blood source, you've lost the nerve. They've taken all that out, and the tooth is essentially dead in the mouth. And our teeth are porous. There's tons and tons of little tubules, and they're porous, and so they just sort of like kind of dry out and die. And the dentist has to fill it up with a material, and sometimes they have to try to stabilize it. So they might use different materials. This is a cast post core. They might use pins. They might use something that looks like a screw. And then the gutta percha itself, this down here is the gutta percha. And that looks like it's almost like rubbery or something. So it's not super radiopaque. So a little bit more radiolucent. So we have a couple different things going on here. We have amalgam fillings. We have porcelain crowns, some more amalgam fillings. So just things can just look things can look so variable. So when I test you guys on this, I kind of try to keep it basic. I try to show you pictures of a composite restoration. Definitely you'll see amalgam. I'll probably do like a gold solid crown and then a porcelain fused to metal, which I don't feel like we've had a great one yet. Okay, this is a good one. So PFMs show a metal core, so a very smooth metal core, and then an outer shell of porcelain. So when the person smiles, you see porcelain, but inside is metal. So you see that in the anterior portion, you see it in the posterior. This is going to be more like a gold crown up here. And then we have some amalgam restorations. Sometimes in one tooth, you can get like some amalgam and some composite. People can have like, I mean, that's not something that a dentist would probably recommend, but sometimes you can have a mix and match. Okay, here's some more. Root canals are harder because they're just used so many. I mean, I'm not an endodontist. Nobody here has probably worked for an endodontist, unless you have. Anybody worked for an endodontist? You're like, I have. You have. So you guys will have more understanding, but we don't have to know it. You just want to know that that is a root canal tooth. That is like your takeaway. This is a root canal tooth. You don't need to know much more, but I do want you to look at some. If it's a pin, it's going to look more uniform. If it's gutta percha, it's going to flow into the natural shape of the canal. So these are some little pins, some little metal pins. They look like metal screws, and that as well. Oh, this is the gutta percha, and this is the pins. See, even I just get myself confused. But there's also something called silver points, and those can also be in a root canal, and those are going to have they're going to be more radiopaque, and they're going to look very smooth. So they're going to look more like that gutta percha, but they're going to be more radiopaque, and they're called silver points. And I think that's on the PowerPoint that has some of the dental materials game. And the neck, oh, it's there. Thank you so much. So see how these look really radiopaque, and they're very smooth and so gutta percha looks less radiopaque, and it usually follows a little more natural kind of look to it. Whereas silver points, these are all silver points, and silver pins, they're all going to have, this is some gutta percha back here, but you see the difference there? They just are going to have more radiopacity. And then that big thing in the middle that looks like a giant screw, that's an implant. Yeah.
A PFM posting core restoration.
So posting core is going to go down into the root, the chamber, the nerve chamber. So core, think of like the core of the tooth, or a post. So that's involving a root canal restoration. And then on top of that, if they put a PFM, that's the type of crown they chose to restore the top. So it's kind of like your roof and your foundation. So the foundation is going to need a post core, and then the roof is going to be either a PFM, porcelain fused to metal, or a gold, or a zirconia, whatever the dentist wants to use. And then, so yeah, here we have different root canals, implant, and amalgams. And this just kind of talks about this. I liked this slide because I liked how they showed a picture of the real thing. So there's, porcelain, zirconia, porcelain fused to metal, Emax crowns, and gold crowns, and then kind of little information about it, which I'm not going to test you on anything there in that picture. I just liked that it gave some of the variety. So dental materials is harder in the way that we don't go into depth. Obviously, we're kind of breezing through it in like 15 minutes. So the big things that I want you to pull from that is the difference between amalgam composite and maybe the different types of crowns. Being able to say this is a PFM versus a full gold cast, or a porcelain crown. Porcelain's going to look much more radiolucent. And then knowing the difference also between the material, again, gutta percha is going to be more radiolucent, silver pins and posts and things like that, or those are going to be more radiopaque. And then if you see a picture like this, if then you know that these are also going to be, they could be variations of composite. So it's not a cavity. It used to be a cavity, but that very defined outline, they can be very old composites that just simply don't have, and you're not going to see that very much at all, but it could be that you come across it. So sometimes the older composites can just look much more radiolucent. There's not a lot of questions on dental materials, but there are dental material questions on the last, I think it's the last exam, the mini exam. There's dental materials and anomalies and periapical abscesses. And that's like, I think that's week 14. So we can go over it too, and we have activities in lab where we can study it again. But so that's all we have for that. So I'm going to stop this recording. I'm sure you guys are like overloaded.